educator. All right, so we got over that, and welcome everyone. Will, there you are again. Okay, so we're getting ready. We've got, it's just about time. Let's give it a second for a few other people to make sure that they're in the room. I'll just say again, welcome, even though it's Sue. Yes, congratulations. Awesome. It's always great to have success stories standing by, and it's always good to keep learning. I mentioned before, although we had an echo, that this is EMS week that we're recording this, but I'm always very grateful for what students do, all students, not just mine, to be certified in EMS, to go out and do such a noble thing. So EMS week or not, we are very happy that you're all here, and we are going to go on and start doing some Jeopardy. Many of you, I can tell from your names, have been here before. We're grateful to have you back. I'm going to, in a second, put up a screen, and then we'll just type in the chat if you want to go somewhere. We have a few surprises hidden in here as well. So that's what we're going to do. Okay. My name is Dan Limmer. I'm the Chief Knowledge Officer at Limmer Education, a co-founder of the company. I've been in paramedic and police work, a teacher, a conference speaker, and public safety for a long time, more than 40 years. Done a few textbooks as well. If your EMT book is the yellow textbook, Emergency Care, that one is mine. My job is to help you succeed. Chris, that's a good plan. We got you covered. We're going to get you there. And the second time you can go back and do it, just so you know. All right, I'm going to put our Jeopardy screen up on the board. Alicia, this is like old home week. Look at everybody coming back here. All right, I got to get to work. We have 5 topics today in this Tournament of Champions. We're going by the National Registry sections: airway, medical and OB, trauma, cardiology and resuscitation, and I mix special populations and operations together as ops and pops. And we can go through and do that. And we have a request already, medical for 200. I'm going to say I tried to make these a little bit more challenging as we go through. Medical for 200 asks this: conditions like pancreatitis and cirrhosis can cause this accumulation of fluid in the abdomen. Conditions like pancreatitis and cirrhosis can cause this accumulation of fluid in the abdomen. Susie, that's why you passed, because you get that right. All right, there we go. All right, I'm going to keep moving on here, but remember, in the chat, you can put your answers through. We'd love to see what you have to say and do this. And again, we're making them a little bit more challenging today. And Will and Susie are correct. That's ascites, abdominal ascites. And you can ask people, is your belly a little bigger than it normally is, especially with that history of cirrhosis and pancreatitis? But 80% of the cases of pancreatitis come from alcoholism. So we find some cirrhosis go there as well. Those 2 organs share a duct. So when this happens, it's important. If you have a lot of fluid in there, you can actually take your fingers, put them on the side, and give them a little tap, and sometimes watch a wave of fluid go across the belly. All right, do we have, oh, I'm going for medical for 500. I'm going right there. These respirations are seen in medical patients with acidosis. These respirations are seen in medical patients with acidosis. What do we call those? Bill just wants to cuss like he does in office hours. A lot of people here are in my live online sessions as part of emtreview.com and paramedicreview.com, and it's great to have you here. Yes, the correct answer is Kussmaul's respirations. Now, why I said this in medical patients is because if you have rapid, deep breaths in a trauma patient, that's central neurogenic hyperventilation. But in a medical patient, it's Kussmaul's. We think about it mostly with diabetic ketoacidosis. However, we sometimes see that in aspirin overdose and other conditions with acidosis. If you see that, that's usually what it means. All right, special pops and ops, we're going for 400. Here we go. Neonatal resuscitation recommends this ratio of compressions to ventilations. Doing some deeper cuts in this. EMS doesn't always spend a lot of time in that neonatal part. It's something that we fortunately infrequently use. However, when we do, we want to make sure we do it well. Neonatal resuscitation recommends this ratio of compressions to ventilations. I'm going to surprise you with this one. This is something that's not taught, and this is why we are in the Tournament of Champions. Oh, Trappa 305 and L. Jackson, look at you coming in with the correct answer of 3 compressions to 1 ventilation. The reason being, many times issues with newborns have to do with hypoxia. And remember, we're compressing if after we try and resuscitate them a bit, try and dry warm stimulate them, if their pulse remains below 60 with a little bit of oxygen, we're going to be doing compressions. Doing that is 3 to 1. So that's what we're doing. We're getting this through to get you all those little nooks and crannies as we go. Special pops and ops for 500. We're wiping out the bottom of the board. We're getting the hard ones. I'm going to go back to the top for the easy ones for a little bit of this, but for 500, oh, look, a picture question. Which of the numbered sections of this NFPA 704 placard is the greatest hazard? And what does that hazard represent? National Registry has the potential to give you images. I think you will see more and more of that. Based on this particular placard, which one is the worst, right? It's not just health or whatever it happens to be. Which one is the greatest hazard? All right, I put a picture in here. I wanted to give it a try. And here's the thing. If we look at health, which is the blue, and we look at flammability. Well, Jessica, I might be with you since we're talking about some radiation and nuclear stuff there. But, all right, Jim, I am 100% with you because flammability in red is the number 2. It's a higher level of hazard than the other choices. Although I do see that radiation, the white symbol is other hazards. Might be reactivity with water. It might be that, the symbol here for some type of radiation. All right, no, definitely. Radioactive is not good. All right, I think we did great on that. Now I'm going to go back up. We've done no trauma. We've done no cardiology and resuscitation. I'm going up to the top of trauma. All right, we'll do airway for 100 next. Joint fractures or dislocations with a distal pulse are splinted in this position. Joint fractures or dislocations with a distal pulse are splinted in this position. All right, there we go. There we go. We're getting some answers in here. All right, I'm going to go on this. I think we're kind of getting this answer here. They're splinted in the position found. Now, should there not be a distal pulse, we have the ability to manipulate it a little bit to try and get that pulse back. Otherwise, we're going to splint it as it is and bring them someplace that will hopefully have orthopedic surgical capabilities. Now, long bones are a little bit different. Long bones, we are going to try and straighten unless one of 2 things happen. And that's generally the big thing is we're going to do it unless an unusually significant amount of pain is felt, because it's going to hurt to realign it, but it does make it better in the long run. And the other thing is if there's any resistance. Long bones, we're going to try and realign. Joints, we leave as they are when there's a distal pulse. All right, very good. So airway for 100 is the next request, and here we go. Inserting an oral airway in a child differs from an adult in this way. Inserting an oral airway in a child differs from an adult in this way? There we go. I like it. I told you I was trying to make these a little bit harder. If anything else, to make you think. Venom, yeah, Venom even got in. Venom got into why, right? So the correct answer, we're saying do not rotate at anatomic position totally. The airway is inserted along the pharyngeal curve, not upside down. The reason for that is because their palate isn't as developed. We have the potential for bleeding if we scrape the airway along that. So we insert it along the normal pharyngeal curve, not upside down. Great answer, and we're going to trauma for 200. The radial pulse is found on this side of the wrist. Looking for a position, description of position. The radial pulse is found on this side of the wrist. And to do that, there we go, Jim, you've got to think about anatomic position, which is with the palms forward. So I'm sneaking in some medical terminology doing it this way. We've got some great answers here. Yeah, right along the radius, of course, Jerica. Jerica, if I called you Jessica before, I'm sorry. And this is exactly right. It's on the lateral side of the wrist. I don't know how many times I teach students, and everybody does what the people in the doctor's office do, and they just put their fingers in the middle. It's like, how do you feel anything? You got to find that little groove and get your fingers in there to feel that pulse. Absolutely. All right, I've got a request to work down trauma here for 300. We can do that. Here we go. This common type of intracranial bleeding is slower because it is usually venous bleeding. This common type of intracranial bleeding is slower because it is usually venous in nature. All right, there we go. We're getting some answers in there. Very good. Hello, Marty. This is awesome. And that, in fact, is the correct answer, subdural hematoma. The dural bridging veins, especially in the elderly where the brain may shrink a little bit, they atrophy a little bit in alcoholics, they can be stretched. So head injuries often start in that small venous bleed, which means in a 12 to 24 or 36-hour window, these things may develop slowly over time. So it's really important that we know these. Now, epidural hematomas, right, they are on the temple. It's a very weak spot in the skull. The middle meningeal artery is there, and that is often arterial, just to differentiate between the two. All right, got a request for cardiology and resuscitation for 100. Here we go. Of the two major types of stroke, this one is less common and frequently presents with a severe headache. I'm not talking about television, which everything appears with a severe headache. In real life, of the two major types of stroke, this one is less common, about 20% of strokes, 17 to 20, and frequently present with a severe headache. Yeah, we're getting some answers in here. All right, I'm going to give the answer. We're moving along in a good clip today. I like that. Thank you all for participating. And the correct answer is hemorrhagic stroke. We have two types of stroke. We have ischemic and we have hemorrhagic. 80 to 83% are ischemic strokes, the most common. Those symptoms are somewhat vague. However, the hemorrhagic stroke, blood being an irritant like that, often presents with a headache, a severe headache, sometimes called a thunderclap or the worst headache I've ever experienced. And those things may indicate a hemorrhagic stroke. Blood is an irritant when it gets in those meninges. All right, I'm going to pick one here. Where am I going to go? Let's go to Ops and Pops. Go to Ops and Pops for 100. An alert patient at an MCI with a broken tibia and fibula, with a pulse of 88, respiratory rate of 16, and B2 and Will, you in the same room is conspiring to get that? Blood pressure 108 on 68 would be tagged which color? An alert patient had an MCI with a broken tib-fib, pulse of 88, respiratory to 16. All right, this is too easy for you all. 108 on 68 would be tagged which color? Yes, everybody's saying that. Yellow. Now, in triage, we tend to over-triage people, make them more serious. In this case, we presented a relatively stable patient with an isolated fracture, but when you make that announcement, everybody, you can hear my voice, walk to this area, this person's probably not going to hop around. That means that they're not red and they're not green, so they are yellow. And in MCIs, we tend to over-triage people as we go through. All right, what did we have before? Cardio for 200. And here we go. One rescuer child CPR is performed at this ratio of compressions to ventilations. I do these because the National Registries has to do a lot of questions to get the cardiology and resuscitation questions they need, and they go into some of these facts. And sometimes it's the easy things that can make you slip up, and I don't want that to happen for you. All right, we've got a lot of answers there, and the correct answer is in fact 30 to 2. One rescuer CPR for all ages is 30 to 2. Child and infant, when you become two rescuer CPR situations, you can do 15 to 2. But one rescuer for every age group is 30 to 2. Right? We're leaving out the neonates. We're just getting our three major categories of adult, the child, and the infant. All right, let's keep with cardiology and resuscitation. I'm going down to 300. Here we go. Without blood thinning medication, this heart rhythm has the potential to cause a stroke. Without blood thinning medications, this heart rhythm has the potential to cause a stroke. Yeah, we're getting some good answers in there. You know, all too often we take our sample history and the signs and symptoms and the medications, and we don't give them the attention that they deserve. So in this case, I think we've got a good group of answers. I'm going to say you're correct. Atrial fibrillation, sometimes called AFib. AFib we can usually live with. Interestingly, from the left atrium to the left ventricle, about 2/3 of the blood just falls through by gravity. So even without a good squeeze, we're going to survive. Our cardiac output's going to drop a little bit, but we'll be okay with atrial fibrillation. But due to that quivering, this is what Tropi said, the heart clots form on the wall. They're called mural thrombi in the atria, and they can break off. And when they come out of the left atrium to the left ventricle, up through the aorta, if they go to the head, a stroke could be coming our way. Blood thinning medications, things like Eliquis, for example, is a very common medication people are taking. And I want you to make those links. Is the person have atrial fibrillation, an irregular pulse? And if you say, do you have atrial fib? I was on a call the other day and I felt the wrist. It was really irregular. I said, you have atrial fib? Yeah. You take a blood thinner? Yeah, this patient had fallen. I'm like, okay, good. But what does the blood thinner do when you fall? Makes you a little bit more concerned about the injuries, the bruises, especially if it's a head injury. All right, I had a couple of requests here. We wanted to go to airway for 500. We have some daredevils here. All right, airway for 500 was the first request. You're ventilating a patient with a BVM and observe a drop in blood pressure. What is happening with the ventilations? You're ventilating a patient with a BVM and observe a drop in blood pressure. What is happening with the ventilations? Yeah, and this is a really big concept. And while I don't ever go out and seek National Registry questions, I have heard a lot of people say this is a concept that's out there a lot. So yeah, the correct answer is that we are being overventilated or hyperventilated, and the intrathoracic pressure has increased. See, normally when we breathe in and out, we have positive and negative pressure. When we ventilate, we only have positive pressure. That positive and negative pressure in our chest helps move blood through my inferior vena cava and get it back to my heart. When I only have positive pressure ventilation and I do too much, it reduces preload. Overventilation increases that intrathoracic pressure and will actually reduce preload to the heart, reducing the cardiac output and reducing the blood pressure. So you may be ventilating an asthma patient or somebody, watch the blood pressure go down. Do you stop ventilating them? No. No, but we often do overventilate in both rate and depth. Remember that the depth of ventilation that you should be doing is only enough until you start to see the chest rise. All right. All right. One other comment, no negative pressure in the chest, lower pressure than the atmosphere. So we have a above the atmospheric pressure and below the atmospheric pressure in the chest. All right, so I had a request from Will, and I missed that one before. Special pops, we did that for 500. All right, I guess we did that. Airway for 500. I'm going down my list to see airway for 300, going into more airway. Swelling of airway tissues in allergic reaction is caused by this. All right, I'm getting where you're going with this. What's the mechanism? What's it called when those tissues swell? Yes, it's anaphylaxis. Yes, it's caused by histamine. But what's it called when fluid seeps out and swells those airway tissues? Yes. And it's really common in airway tissues because of the fact that one, it's very, very vascular, and also it's very, very thin tissue and things that we can see. Yeah, it's the correct. I was going a step deeper, but you're all keeping me honest. Angioedema. What's interesting is that you can get this from anaphylaxis, and this is often what causes the airway compromise. The tongue, the airway tissues start to swell because the capillaries become more permeable. Increased capillary permeability, which means it's letting out all that fluid into the tissue and causing that edema. And that's called angioedema. Well, if you notice in all of these things I do, anytime I talk about this, I always use words like even like capillary permeability. I could say leaky capillaries, that's accurate, but you're going to see the words capillary permeability if you are there, right? Here's a quick note. Some of the questions, ALS or paramedic level, don't remember going over angioedema in my EMT class. Luke Z, some EMT classes don't do this, but I push this. It's my job to give you this information. When people come to Limmer Education, Jeopardies, or anything we do, I try and push it a little bit more. The National Registry will use that word. And every class doesn't get every word out. I'm not blasting your class, but I do this and I use those terms for a reason. Most people come out of the National Registry and they go into one of the study groups on Facebook and they say, I didn't know what these words were. I didn't know what half the words were. I don't speak Latin. And that's why we go through them here and why I use them. Well, angioedema is a sign that's really important, and it really depends on the type of reaction. One of the comments is angioedema is a late sign. In the airway, angioedema happens more commonly, as does nausea and vomiting, with things that are ingested. And that's because those things actually go through the oral cavity and they're swallowed down through the throat. So the contact of something that you're so allergic to actually will make that happen relatively quickly. Of course, it depends on the severity of the reaction, how allergic somebody is to it. But again, because the tissues in the airway are so vascular and some are very, very thin, and the space we have is narrow. That's why it's important. And whether it's a late sign or not depends, again, severity of the reaction, and many times ingested things like shellfish and peanut butter that's there can cause it relatively quickly. All right, let me see here. All right, I'm just going to pick one here just so we go. Let's do cardiology and resuscitation for 400. After traveling through the mitral valve, blood is in what part of the heart? After traveling through the mitral valve, blood is in what part of the heart? We have some new people coming in. We got people that have been answering every question. Thank you to the people that are jumping in now and ones who've been doing this every time. Just some trivia while we're doing this. The mitral valve is named after the hat a bishop wears called the mitre because it has two flaps on the top. The mitral valve. Tricuspid valve is between the right atrium and the right ventricle. The mitral valve is between the left atrium and the left ventricle. So after traveling through the mitral valve, blood ends up in the left ventricle. And what I do here is I just do anatomy, but I make it so it's functional. National Registry doesn't give you a lot of things without some application. So the correct answer was left ventricle. Now let's clean up some of these little ones up here, some of the easier ones. Medical and OB. This condition occurs in third trimester patients who lay supine. This condition occurs in third trimester pregnant patients who lay supine. Yes, Tom, also bicuspid. Again, like I said, that hat the bishop wears has got two valves, and the tricuspid is on the right side. Yeah, you guys are doing awesome. This one, if this wasn't a challenging Jeopardy, I might have moved it down a couple, but I want to make this challenging. This condition is called supine hypotensive syndrome. So what do? We put some padding under the the right side of the patient to push the uterus off to the left. And why is that? It keeps the uterus off the inferior vena cava. So we put some padding under the right side of the patient, which shifts that gravid, that big, full, baby-filled uterus off to the left. And in doing that, can relieve the hypotension. Now, if you're doing CPR in a third trimester patient, you will manually displace that uterus. So somebody will be on the left side of the patient, reaching across to the right and manually moving that uterus over because you want the patient to be on their back for good compressions. So that's done manually. Exactly. All right, let's clean up some of these 200s here. Let's go to airway. The point at which the trachea bifurcates or splits into two. I love try before you buy. I like that. Look at y'all jumping in with that. It's the carina. One of the things we're looking at in the next edition of my EMT book, which we're working on now, is making sure that, one, we are really good with terminology, but also we know that EMTs will be helping paramedics in things like intubation and the monitor and end tidal CO2 and things like that. So I want to cover that more. One of the things about the carina is if an endotracheal tube is advanced too far, because of the angles of those two things, they don't bifurcate evenly. Okay, the left has a bigger angle, so the tube generally goes into the right main stem bronchus. Little trivia there. We always listen over both lobes of the lung, but if we go too far in, there's a chance it goes to the right, and the absent breath sounds will be on the left. The carina is the point at which the trachea bifurcates. You guys are doing awesome. Ops and pops for 200 to whittle down. Emergency vehicles must be driven with this in mind towards others on the road. Emergency vehicles must be driven with this in mind. Like you guys are awesome. Towards others on the road. Yeah, that's something that you just really have to know. And I have to tell you, a lot of people come out and have when we used to give the answers by get results by section in the National Registry, operations can be a problem. There's some nooks and crannies there, and the way the registry asks questions can be challenging. I couldn't fool you here, though. The correct answer was due regard for the safety of others. And that generally means stopping at all intersections and red lights before you go. The nature of accidents, we obviously think about not injuring ourselves or anyone else, but lights and siren are not any sort of immunity for caution. Due regard for the safety of others. All right, let's wipe out the ops and pop section. Let's get that done. Down for 300 here. The C in CBRNE stands for which threat? There we go. We're getting some good. Can anybody name them all? While we're waiting, getting these answers here, can anybody name them all? It takes longer to type this one, I know. Bio, radiological, nuclear, and explosive on top of chemical is the C. Awesome. Every little bit that we can put in here to get you knowledge in these nooks and crannies, we are going to do. And we are doing it well, and we're doing it in good time. Please stick around after we get through the rest of these Jeopardy sections. We're going to go over 2 National Registry style questions on the end. Baz, I'm very glad that you find these helpful. All right, I'm doing medical and OB for 300. This anatomical reference point is between the anterior superior iliac spine and the umbilicus, or belly button. This anatomical reference point is between the anterior superior iliac spine and the umbilicus. It's a point. Do you know who it's named after and what you will be palpating if you palpate there? What? Oh, all right. I'm glad that I'm getting you with some of these because it's my job to challenge it today, and this is an outstanding group. I'll give you a little bit of a hint. This is going to help you identify where the appendix is in the belly. And it is a Mick. I'll give you a hint. It's not McSteamy or it's not McDreamy. If you watch Grey's Anatomy, it is neither of those. McRoberts is a position that we sometimes put pregnant women in for shoulder dystocia and the baby that won't deliver. But a couple of us got this here. It's called McBurney's point. It's a third of the way from that protruding hip bone up towards the belly button, the umbilicus. It's a third of the way. And that is where you will find the appendix. Remember, appendicitis often starts around the umbilicus, the belly button. That's because visceral organs like their appendix don't have great nerve endings. So sometimes the brain interprets where they report back to the spine as the spot where the pain hurts. Remember, visceral pain is vague. But when the appendix ruptures or gets really inflamed and it's banging against the peritoneum, anytime the peritoneum is inflamed, that peritoneal or somatic pain we can identify, then we feel it in the right lower quadrant. So there's a little bit of trivia in here. We're going through and doing some hard ones. It's called McBurney's point, and it's where we find the appendix in the body. All right, we've got some 400s. Let's go left to right. You suction for this long in an actively vomiting adult patient. You suction for this long in an actively vomiting adult patient. I'm going to make you mad on this one. I just want you to know. On the way out, I totally get. All right, are you guys ready for the answer? We got 10 seconds here. We got 15 seconds here. I'm going to give you a different answer. You vomit for as long as you suction for as long as it takes to clear the airway. Yeah, I'd love it to be less than 10 or 15 seconds, but this actively vomiting patient, see, here's the thing. This 10 or 15-second rule, which is total garbage, was started in the 1970s when nurses and docs would teach EMT classes. At least this is my take on it. And if somebody's intubated, sure, you can take that little catheter and snake it down in the tube and suction for 10 to 15 seconds, then take it out and ventilate. But think about it. Yeah, actively, as long as, see, here's the thing. What's going to kill the patient faster? If you take a couple of big pieces of potato and steak, coated in 2.0 hydrochloric stomach acid, and say, oh, I've been ventilating for 15 seconds now. I've been suctioning for 15 seconds. I better ventilate now. And you take and you ventilate it and they go into the lungs, they are going to most likely die. 90-95% chance they'll die from aspiration pneumonitis, from potatoes and acid in their lungs. Right? We suction out as quickly and efficiently as we can, and we take that 10 to 15 seconds was never particularly valid. Yes, it would be great to keep it there. If the patient's intubated, sure, you can do that. But what's the alternative? 15 seconds is up. Somebody's timing you. You've got a pit crew there for your suction. So 15 seconds is up, and you look, and there's still junk in their throat. Picture ventilating that. Where's it going to go? Into the lungs. Would you want that done to you? No. If somebody's doing a barforama, you're going to be suctioning for longer than 10 or 15 seconds, and that's okay. You can do it in 10, you can do it in 15, great. A lot of the people I've seen barfing, they either ate a huge pasta dinner or they've been drinking like a fish, and it just keeps coming up. And we got to get it out of there. All right, I did that one on purpose, and this was lower down the list, and this was a little bit of a trap, but I want to teach you. Be very careful of anything that you've been told by an educator or a practitioner that has the word always when it applies to the National Registry. The National Registry writes questions that sometimes avoid that always issue, right? Only suction for 10 or 15 seconds, never suction for longer, right? Give oxygen only if the saturation is below 94%. If they're in shock or if they're cyanotic, even if it's 95, we're still going to give them some oxygen. Avoid always and never on the National Registry. Answer each question. You pick the best one from the 4 choices you're given, even if the one you want isn't there. All right, medical and OB for 400. Seen in psychiatric patients, this finding is defined as a false belief. Can't hear me. Can anybody hear me? I've said 2 people say you can't hear me. Can anybody hear me? All right, Baz can hear me fine. All right, I got a couple people that can hear me. I'm going to keep going. All right. Yeah, oh, you guys are good. You know, psych emergency, you don't get a lot that come up in these quizzes, and I wanted to do something. A lot of people can hear me, but some can't. I don't know what to do about that. Well, I'm going to go and give you the answer to this. The answer is correct. It's people are out there. Absolutely. It's called a delusion. A delusion is a false belief. Now, they can be paranoid delusions where you think someone is out to get you or following you, right? It can be a delusion of grandeur where you believe that you're a religious deity, a god, or some type of thing like that. You might think that you're the president or somebody famous in history. Right? Those are delusions of grandeur. Paranoid delusions, there's many different types, but a delusion is a false belief and a sign of a psychiatric condition. All right, as we go on, let's go to trauma for 400. Oh, and another photo. This burn would be described as what depth? What depth would you say this burn is? Now we've got all the different choices here. Remember that burn descriptions as far as depth refers to the amount of tissue that's burned. So in this photo here, this person actually fell into a campfire. This burn would be classified as a partial thickness burn. Yes, there is charring of that superficial layer. However, we're not deep enough through that next layer to make this a full thickness burn. You also see some blisters on the hand characteristic of that second degree burn. And this is one of the things that I think is really important as we talk about this, is that yes, some of that skin is charred, and that's a result of the temperature, and a certain amount of that burned away, but it hasn't gone down through that subcutaneous layer to make that a full thickness or a third degree burn. This is partial thickness or second degree because of the depth and also because of the blisters, right? There's no fatty tissue. We're not down into that. This was probably pretty hot, pretty quick, almost like searing a steak on the outside. You get a little bit of burn, but it's not deeply cooked. Only in EMS would somebody come up with an analogy like that one. All right, let's do trauma. Oh, that's the same one. We just did that, right? Yes, we did. All right, that's not going away. Let's go to trauma for 500. Oh, okay, I went in a little trivia here. Your patient has lost about 1,750 milliliters of blood. What stage or class of hemorrhage would that place them in? I'll give you a hint. There are 4 of these. Any math people here? This would be about 30 to 40% of blood volume. All right, and the correct answer here, just to make sure we go through this well, yeah, Todd, this in fact is the 3rd stage or class of hemorrhage. Generally 1,500 to 2,000 mLs, about 30 to 40% of blood loss. More than 40% is a class or stage 4. Stage 1 is less than 750. It's like a blood donation. We've lost some, but we generally tolerate it well. Well, that puts our second class, or second stage, in that 750 to 1,500 ml range. And that's where we start to see signs and symptoms, start to see some compensation. Then the third here is where we start to see decompensation. All right, so about 1,750 mLs of blood would put them in that 3rd stage or class of hemorrhage, probably getting to the point where they are going to decompensate. All right. We have 2 more left. Let's do cardiology and resuscitation for 500. And we'll get into a pediatric question. This is a congenital heart abnormality that has 4 different defects. This is a congenital heart abnormality that has 4 different defects. And 4 is the big clue here. More than we have time to go through and do this, but this is the kind of word you see in a pediatric question on the National Registry and totally freak you out. I want to pre-freak you out, since this is the Tournament of Champions with challenging questions all the time. the recent National Registry grad has got this, and we've got some great answers here. This is one that sometimes you even don't know how to pronounce, but the correct answer is the tetralogy of Fallot. And one of these, I won't go through all these, is a ventricular septal defect, a very, very common birth defect, which involve a hole or holes between the right and the left ventricles. And I had a question like this on my NREMT exam. They are there. These questions are out there. There are several congenital abnormalities. I don't know if you have to go out and necessarily study these, but use the words. If you have choices, 4 different things, tetralogy and 4 will hopefully get you there. I have 1. No, I don't. That was the last one. I am totally done with these. All right, because at 400 we already did. I'm going to put up 2 National Registry style questions for you to finish this up in this session. And here is the first one on the screen for you. Take a moment to read this, and then we will discuss it. Now we'll say this is oral glucose in choice A. If you're a medic, you could say administer a IV of D10 if you'd prefer. Jerica, you can't answer like that, but the National Registry won't let you. You've got to pick one. And I think we're pretty much between A and C on this one. Let's look at the question. There's a confused 74-year-old female. She has left-sided weakness. She can identify her husband and follow your commands, but she's unaware of current events. Pulse is 70, respirations are 14, blood pressure 142 on 74, saturation is 99% on room air. That's good. Blood glucose level is 52 milligrams per deciliter. You should. Well, we're not going to administer oxygen because she's 99%. And I don't believe anyone chose activate a stroke alert. So that's good. So we're between A and C. Now, there's a couple things here. Some people, every question, it depends on what you value, what you look at and give the most prominence in your head, right? So if you have left-sided weakness, unaware of events, things like that, and you're thinking stroke, you think, well, I got to do a stroke assessment. But you've already done a blood glucose and it's 52. By the way, you really can't call a stroke alert in without a blood glucose. 52, that's low. 70 to 110 is the normal blood glucose. If you've been told you can't give glucose to a stroke patient, that's not true. What you can't do is make their blood glucose go through the roof. We want a patient normoglycemic, even if they're having a stroke. Let's say she's having a stroke. Getting that blood glucose up to a normal range is good because the brain is going to do even worse from the stroke if it's hypoglycemic. It won't heal well. It won't function well. So in a stroke patient, we want it normoglycemic. In this case, the correct answer is choice A. Administer oral glucose because you have a demonstrated hypoglycemic condition here. And I've got to tell you, as an old paramedic, you can see I got this here. I can't tell you the number of patients I've walked into and said, oh, this is going to be a huge stroke. Take the blood glucose and it's low and you give them some glucose or some dextrose and boom, everything is symmetrical again. This is why we have to be thinking clinicians. And this is why if people are saying, oh, the National Registry is BS, blah, blah, blah. You know what? This is what you should do on a call. You already know she has left-sided weakness. Or you can do a stroke assessment and see what else, but she can identify her husband and follow your commands. You've already done a pretty fair amount of assessing on this, and you have a blood glucose that tells you she is hypoglycemic. As such, correct, Chris? 70 to 110 milligrams per deciliter is the average what the normal blood glucose reading is. All right, so don't let anybody tell you, oh, the National Register is not real. It's they try and trick you. No, they want to teach you to make decisions. What do you do? On this question, what you want to do? You want to push the easy button. That was easy because you can fix this by doing the blood glucose. I would even bet you can back. And don't say, well, 52 isn't that low, because it's so variable person to person. It really, really is. All right, let's look at the next and the last question. You've been sticking with me and answering these questions expertly. Here's the last one. Take a look at this, read it yourself, so I don't give you any answers away with my voice, and we'll go through this in a little less than a minute. All right, for the people that are putting the letters in right there, he's had all his vaccinations. Do you think that means anything? All right, yeah, I get that, but his lungs are clear. Laryngotracheal bronchitis is croup. Larynx, trachea, bronchitis, those lungs are going to be junky. And Jerica, I'm going to agree with you on this one. But it's the Tournament of Champions. I picked a challenging question here. So, a 9-year-old male complains of pain in the middle of his chest. The pain increases with deep inspiration. His mother tells you he's had frequent coughing for the past week. She denies any other medical history and tells you he's up to date with his vaccinations. His lungs are clear. Pulse is 110, respiratory rate is 18, blood pressure 110/70, setting at 97%. All right, pertussis is whooping cough, and there's a vaccination for that. That's the least likely. Laryngotracheal bronchitis. Now, somebody got mad at me for this question one time. Oh, come on, nobody uses that. Well, the National Registry could. Okay, it's croup. I get it. I get it. That the larynx and the trachea, it's gonna and bronchitis, this is gonna be a noisy condition. This isn't a quiet condition, that one where his lungs are clear. So you look at a 9-year-old, and it's 9-year-old's a little old for croup, right? So we get rid of pertussis, we get rid of laryngotracheal bronchitis because neither of those make sense. But is this kid having a cardiac event? No, because it increases with deep inspiration. He's been coughing all week. What do we think happened? He probably pulled a muscle in his chest or has a little bit of costochondritis because he's been coughing. When he takes a breath, it catches, right? But he's 9. So chest pain of a non-cardiac origin. B2, I am glad that you like that. This one sometimes makes people mad, but it doesn't stop me from giving it to you, because my job and everything that we do at Limmer Education is about helping you pass, giving you easy questions that make you feel good doesn't help you. You need to be pushed. You need to have the experience like you're at the National Registry, see words you don't know, and learn how to come around and still pass. When the paramedic national asks you, you should suspect questions. We should think the worst? No, no, no. I would say no. What you should suspect, that's a differential diagnostic question. And don't always pick the worst, because right in this case, you could say croup or pertussis. What is it? This kid probably pulled a muscle or something. It's not always the worst. It's the one that makes the most sense. And look at how this question is set up, right? Lungs are clear, rule something out. Has vaccinations, rules something else out. 9-year-old, yeah, deep inspiration, it's pleuritic, rules out A, and it leaves us with B. You should suspect EMT, AEMT, or paramedic is a diagnostic question. Use your differential diagnostic skills to rule out all the others, and that's going to leave you with one. Yeah, deep inspiration is in fact the key word here. And I'm glad someone said that's a good question, because you can get mad at me. I'm totally good with that if that's what you want to do. But if people look out of the registry, I never saw some of that stuff before. It's what we do. It's our job to prepare you better than anyone else at Limmer Education. That's what we do. All right. So as we go on, that's me, Dan Limmer, at emtreview.com and paramedicreview.com. I do this every week. We don't always play Jeopardy, but I go through questions, usually 10 or 12 questions a week. Sometimes we do polls, sometimes we do little bits of games. I do live review all the time. Luke Z, I keep these to an hour. I only have 2 questions that I put up on the screen. But if you like this thing where I'll put a question up and we'll explain and teach about it, emtreview.com and paramedicreview.com. I do this live every week. As a matter of fact, my next one is tomorrow night from 8 to 9 p.m. Now, for those of you listening to this recorded, it's going to be a little bit different. But for those of you that want more of this, emtreview.com, paramedicreview.com, this is what we have. We have lots of things on there besides these live reviews, and we have all the new style National Registry questions, all the new ones, the drag and drops and putting things in order, and the buttons that you pick. We've got them. Will, you do come every week. There are several people here that apparently can't get enough of me and come to Jeopardy too from my live sessions. But I'm here for you. Limmer Education is here for you. I'm very grateful for you being here. I'm very grateful for everything you do to succeed in class and go out and do good things for people. All right, Luke, your exam is Wednesday. All right. If you're going for the exam, study tomorrow. But Wednesday, be good to yourself. Don't go out drinking. Don't study until the wee small hours. Don't sit in the parking lot and stress. Everything, if you're taking the exam Wednesday, everything you know Wednesday, you're going to know Tuesday night. Tuesday night, dinner time, until you take the test on Wednesday, just be good to yourself. Tomorrow night's 8 o'clock Eastern Time, 7 o'clock Central. And as we said here, we do have several other Jeopardies there, and we go through. This was the Tournament of Champions, and let me tell you, you all were champions. Thank you very much for being here, and Limmer Education will be popping something else up here again before too long, and come see us at emtreview.com or our limmereducation.com site, where you can find all of our products. Go out there, stay safe, do great things.